and what you're doing is definitely making a difference. So I'm going to go ahead and share my screen. As I share my screen and we're kind of going through this, we are a small group, so I think we do have the luxury and opportunity to kind of discuss questions if they come up with each other in person. So if you do have a question, I will keep an eye on the chat. Feel free to just throw it in there. But if you also want to raise your hand or just unmute and kind of ask your question, that is more than acceptable too. So with that, we'll kind of dive into it. My goal for this presentation is that by the end of it, you'll be familiar with some of the trends, recognize signs and symptoms of a possible overdose, apply the appropriate steps to responding to an opioid overdose, and then be able to describe the proper use and administration of naloxone if you had to explain it to somebody else. So let's just dive into it. So we are currently in what the CDC calls the third wave of the opioid epidemic. This was initiated in about 1999, maybe a little bit sooner, with the really stark increase of prescription opioids. Most prescribers were under the impression that these had no repercussions, that there were no disadvantages to using these medications. And quickly, within a couple of years, we saw that there is a high addiction potential, but also a high overdose potential when it comes to using these substances. As our legislation got tighter around prescribing practices and dispensing practices, we saw the second wave of the opioid epidemic in the form of heroin. Heroin really started to spike in 2010, but it was certainly around prior to that. And it became just a cheaper, more accessible alternative to patients who were not able to receive prescription opioids. Now we are coming into this third wave, or we are pretty much in the third wave of the opioid epidemic, which started on the East Coast around 2013. Here on the West Coast, specifically in Washington, it started closer to 2016, 2017, and definitely around the time of the pandemic, we saw a sharp spike in fentanyl use and other synthetic opioid overdoses. And so this sharp rise in synthetic opioid use is what is being termed the third wave. So this is what we're seeing more commonly now. However, in Washington State, we do still have some diversity in the opioids that are available and what are causing overdoses. However, I add these stats just to kind of present a scope, present a picture of what we're currently seeing within our state. The number of opioid overdose deaths has increased dramatically from 2019 through 2021. And we should be getting data for subsequent years from that too. It is just not finalized and published quite yet. But you see from 2019, there were 827 deaths due to an opioid. And in 2021, there were 1,619 deaths, which is unfortunate in and of itself. But it's also unfortunate because Washington had some really good harm reduction measures put in place where we started to see a real decline in our opioid overdose deaths prior to 2019. So that sharp increase kind of came as a double whammy. Out of those 1,619 deaths, about 68% about a quarter of them involved a synthetic opioid. And most of those were specifically synthetic fentanyl that is illicitly made and distributed within the United States. Now I have some more specific data to Spokane County. I wasn't sure where everyone is located, but in Spokane County, we are also seeing the same thing. About 3/4 of all of our overdose deaths in 2022 involved fentanyl, or involved an opioid, most of which involved fentanyl. And we declared a state of emergency for the fentanyl crisis due to the overdoses, but also to all of the other implications that we are well aware come with active addiction, specifically to something like fentanyl. And just to kind of put it in perspective, I think some people think we have a better understanding about what this is and better harm reduction measures. And these more recent stats haven't been released yet, but unfortunately it seems to be trending that it's still on the uptick. And so a picture of this was released from the Spokane Fire Department, where they described in the year 2024, this year, in the months of January and February, they responded to an average of 6 overdose calls every day. And while not all of those thankfully resulted in death, they did result in the need for naloxone to reverse that overdose. And so that was a total of 249 overdose calls in those first 2 months. So that's kind of the state of where we're at. And how we typically see this in the community, it is most commonly in the form of fentanyl. And this can be seen in several different ways. I like to show this just so that people, especially those that are in environments where they may be interacting with new people or different substances, are aware of what it looks like. This should usually only be shared with adults. This is adult material. It is not recommended to share with kids, but for this adult audience, we are still seeing fake fentanyl in the form of fake pharmaceuticals. So I have 2 images on here. The traditional Mexi Blues, which we have most commonly seen, fake fentanyl mass-produced and distributed. They look identical to those oxycodone 30 milligram tablets, but it's pretty well known now that these are all fentanyl in them. They're not pharmaceutical products. Then we also have fake benzodiazepines that tend to be adulterated with fentanyl, other illicit substances like cocaine, methamphetamine, things like that. Do you have a question?
Make sure everybody's muted.
Yeah, and feel free to unmute if you do have a question, but if not. Okay, so I'll keep checking along. What we are also seeing is different variation of these tablets. So I have here on the top right corner, the rainbow tablets. So they are kind of a little bit more fun looking, a little bit more like party drugs, but most are still imprinted with those M and 30s on them. So they still kind of have that essence of the Mexi Blues, but they can look very different. Other ways you can see fentanyl is in powder form. So the top row, I have powdered fentanyl. In the bottom row, I have powdered heroin. They do look similar, but they are different substances, right? Heroin tends to be a little bit darker and in a little bit higher quantities. If it is straight fentanyl, you need very little quantity in order to see an effect. I also have on here the bricks. So these bricks of fentanyl can be colored or they can be straight white, but this is another way we are more commonly seeing them now. Still not the most common way, but a little bit more common. And the most common way patients are ingesting these medications or these substances is through smoking them. So it is rare that a patient will be swallowing these tablets. It does happen, but it's more common that they are smoking them. So if there is paraphernalia like burned foil or a lot of hollowed out pens are what we're seeing, that is typically what is used to smoke these substances. So this is what it looks like out in the community. And so with the third wave of the opioid epidemic, I get a lot of questions, especially about fentanyl, because there's so much misinformation out there. So I wanted to address a couple common concerns that I've heard plenty of times to hopefully, I don't know, come at this a little bit more evidence-based than some of the misinformation is. And Sarah will be distributing out these slides as needed. So all of the information that I got these slides from are listed on the slides themselves and on the end slide for resources. So you can look into it further if you need to. The first thing I get asked a lot about is secondhand smoke. So I have both patients, caregivers, and then just community members who are in spaces that are shared, that there might be active drug use going on, just wondering about secondhand smoke. Harm from secondhand fentanyl smoke is very unlikely. Fentanyl in and of itself is a very fatty molecule, so once it does get inhaled, it does tend to stick to our fat cells, and it gets distributed in the body very quickly. So from what we're seeing, there is very little to no drug that is exhaled upon that secondhand smoke. There was a study done from the University of Washington that showed contamination from secondhand smoke did not produce enough contamination to cause harm in passengers in public transit spaces. However, the disclaimer is secondhand ingestion of any type of smoke can just be generically harmful to your drug, so general precautions can be taken. Regular masks, specifically N95 masks, can help protect against any type of vapors or smoke, including cigarette smoke or other vaping solutions. But the substance in and of itself is not as as not as likely to cause harm as I think some other sources are describing. Another question I get asked a lot, specifically because of some news stories that have come out in the past, is if they touch a fentanyl powder or a tablet, is that going to cause them to overdose? Does merely kind of acknowledging these substances increase your risk because of their potency? You cannot overdose just by touching fentanyl, specifically the illicitly manufactured fentanyl. Yes, if you touch a patch that is pharmaceutically made, those are designed to go through your skin, so it will absorb through your skin if you touch a pharmaceutically made patch. But the different powders and pills and blocks or bricks that we are seeing of the illicitly manufactured fentanyl, you cannot overdose just by touching that. Your skin's a great barrier. It is going to be a barrier to this substance as well. You still want to avoid touching large amounts of this, specifically of powder. What we are trying to avoid is displacing it so that it's coming up into the air, because if this substance does touch, especially the powder formulation, any of your mucous membranes, so thinking of those pink moist places like the inside of your nose, the inside of your mouth, if you do have cuts on your hands or skin, if it does come in contact with those types of areas, it can get absorbed in that way, and then you can experience effects because of it. So if you have gloves or other PPE like an N95 mask, that is going to be a good protection. So basic PPE measures are going to be a great protection. Caveat there, if you are holding something for a very long time, the length of time that you're holding it, so if you have a bunch of pills in your hand and you have sweating, that can, or if you have some type of alcohol-based hand sanitizer residue on your hand, sometimes that can increase how much is absorbed, but it would take a lot and you holding that substance for a really long time in order to actually be affected by it. And if you do unknowingly touch a fentanyl product, the best thing you can do is to wash your hands with soap and water, just like you would for any other time. So singing your happy birthday song to actually get that soap to do its job. You want to avoid putting those hands that you have touched something with directly in your nose or mouth. Again, if it touches those mucous membranes, it can absorb through your skin. If you do have some on your clothes, you can use an alcohol wipe or an alcohol swab to kind of take a first pass at it, and then you can launder it just as you normally would. Just throw it in the washing machine with your regular detergent. And then if you do have a large amount of pills or powder discovered, you can call Crime Check. This is the Spokane number, but on the next slide, I have the Seattle number as well. These are for non-emergency services. And so theoretically, no one is supposed to have Schedule I drugs on their person, and police should be notified. Whether they respond is up to them. So for mass fentanyl contamination, in different areas, you may be entering spaces that you just don't know what is in there, especially for a lot of different social work capacities. Sometimes this can come up. So if you do see something where it looks like fentanyl may be mass produced, so specifically if you see that white powder physically on surfaces and walls, then you just don't want to enter it. You don't want to touch anything in there. And that's when you definitely want to call Crime Check in order to appropriately clean and sanitize the area, but also confiscate whatever materials were left behind or were actively used there. I have on this slide a few images just to be helpful if it is ever a situation where you might need to recognize it. I have two different types of pill presses. This is what is used to make those M30 pills, whether they are blue or colorful rainbow colors. You funnel a bunch of powder into the top kind of funnel looking area, and then you crank it in order to pop out those pressed pills. And the other two pictures are more of the mixing mechanisms or how people are kind of weighing out those powders. So you see any layers of powder, you are going to exit that and get someone else involved. So this is the Crime Check for Seattle and Spokane number. Another misconception I hear a lot, especially with harm reduction measures, is that naloxone doesn't work with fentanyl, that fentanyl is too strong and it's not even useful to use naloxone. And that's not true. Naloxone does work for fentanyl. Because of its potency, you may need a few more doses or you may need repeated doses. And that's just because fentanyl may be working longer in the body than it is than the naloxone's in the body, or it could be that that fentanyl there's a lot in the body. And so we need to displace more of it with that naloxone in order to see the reversal effects. So if a person is overdosing from fentanyl, does that put you at risk for an overdose? It does not. Again, we can't absorb fentanyl through our skin. So if you have a reversal agent, you are able to safely use it on a person who is overdosing from fentanyl. Does naloxone work to reverse a fentanyl overdose? Yes, it does. And when should you call 911? Anytime you may be considering that there is an overdose. If you have someone unresponsive, you should call 911 first and foremost. So let's see.
Bridget has her hand up for a
Oh,
question.
yes, Bridget, go ahead.
So there are times, especially in our shelters, when just because we're not very good at making sure we're rotating our naloxone or not naloxone supplies, we come across doses that are outdated according to the package. I've heard different things about you can still use it, you can't use it.
I would use it.
Okay. All right,
Yeah,
thank
I'm
you.
actually working with some med chemists now. I am not a chemist by training, but we're testing expired doses of naloxone. And so with the IV formulation, there were a couple, and they only tested 12, but there were a couple that were still stable at almost 90%, 20 years after their expiration date. We don't know.
20 years?
Yeah, and that was with IV, so in a hospital setting. So we don't know if that's the same with the intranasal naloxone. It's a different formulation. It's also usually in different spaces, right? I carry my naloxone with me, so that might alter things too. But it's the general consensus is that as it ages, it may become slightly less effective, but we don't see large amounts of harmful chemicals that are being created like we do in other drugs. And it's always better to have maybe a little bit less effective naloxone than no naloxone at all. So if that is the only product we have on hand, I would highly recommend using it and then replenishing your stores afterwards.
Perfect. Thank you. Like I said, I kept hearing different. So I'm just going to say, no, Nicole said use it. We're using it. We're
Keep your
not throwing
fingers-
it away.
Yeah, keep your fingers crossed for funding. Hopefully we're able to test. I think I have about 3,000 expired naloxone products from first responders. So if we're able to test them, maybe we can get you some actual evidence to support what has been seen out in the field. But that is kind of the hypothesis thus far.
Okay. Thank you.
Of course. Same thing goes for, and the package insert, it says to keep it in these pristine conditions. It's better to have naloxone on you than to have it in a temperature controlled, light controlled space. So if more harm reduction is done if you have it on your person as opposed to keeping it locked in a medicine cabinet. So I'd always advocate to have it with you, even if it might get colder or hotter than those package inserts as well. So that's a great question, Bridget. So what is naloxone in and of itself? It's a really strong reversal agent to opioid overdoses. So when we have opioids in our body, any type of opioid, it's going to bind to our opioid receptors. When we have too much, it's going to cause adverse effects like respiratory depression. But when we enter an antagonist like naloxone into the body, it actually has a really tight affinity to the receptors. Naloxone still has a tighter affinity than the fentanyl does to the actual receptors themselves. So it's going to kick that opioid off of the receptor and it's going to block all activity. So it's going to block all of the good effects of opioids, but it's also going to block all of the bad effects of opioids too. So we want to see that person start breathing again. That's the main thing we're looking for. And so that's essentially how naloxone and our reversal agents work for opioids. So an overview of naloxone, overall, it's a very safe medication. It has actually one of the highest safety profiles of any drugs on the market, and that's because it has one job. It's safe in all populations, so you're going to use the same dose for children, adults, people who are pregnant, people who are nursing. You would even use the same dose for animals if you had a dog or a cat get into your prescription medications, etc. And so we have seen all of the different products used maybe not ideally, but used across the board for animals and people. But what I want to focus on is the people. So it will not cause any additional harm in these different patient populations. If there is no opioid in the body, there's going to be absolutely no effect. It only works on an opioid overdose, which is good and bad. It's good because it's not going to add additional harm if this isn't an opioid overdose. So other emergency situations can sometimes look like opioid overdoses. That includes a really bad asthma attack, a hypoglycemic attack, overdoses by other substances like benzodiazepines can sometimes look like an opioid overdose. If you use naloxone in any of those situations, it will not make any of them worse. It will only have an impact if there are opioids in that person's system. It only lasts between 30 and 90 minutes. So naloxone in and of itself is a pretty short acting product. So we want to make sure that we have other supports in place. So most opioids are lasting in the body between 2 and 4 hours. Specifically with these synthetic opioids, we're seeing those overdose symptoms very close to when they actually ingested the substance. So it's at that start of that 2 to 4 hour range, right? So the naloxone might very well exit the body while we still have opioids in the body. If that does happen, we can see a second overdose from the same ingestion. So we either might need later doses of naloxone or they need supportive care in a hospital situation. When in doubt, always call 911. No one gets charged for an ambulance until someone gets transported to the hospital. And in some counties, I have learned recently, people sometimes don't even get charged through different community grants to get taken to the hospital, but those are typically in more rural areas. In bigger counties like Spokane and Seattle, they will get charged to be transported, but they will not be charged for the evaluation then and there. But with naloxone, you can give multiple doses safely. The largest amount I have heard of with synthetic opioids is 33 doses of naloxone before they were able to get them to the hospital. But yeah, so it is safe to keep giving multiple doses if it is helping. So before we get into how to use it, I did want to highlight where to get naloxone. Washington State is very accessible for naloxone. We have a standing order, which allows you to pick it up at any pharmacy, both behind the counter and over the counter. The standing order is basically a prescription that is written for every Washingtonian. So this allows you to pick up all of these different naloxone products behind the counter from the pharmacist, or now, as of last summer, you can get it over the counter for $44. You can also get it delivered to you. So at stopoverdose.org, they have a bunch of different avenues to get it, but I have here the phra.org/naloxone. This is a form that you can fill out. It's a Google form. There's one for King County and one for all of the other counties that you are able to get naloxone mailed to you for free. So they do take your information like your address, but they only use it to ship you that naloxone. I used it, and that's how I have naloxone to carry on me. And I think it has been very beneficial. DOH also does provide naloxone kits to programs. So if you are part of these different organizations that do come in contact with people who use drugs, then it is a way to have naloxone on hand that is most often free, if not relatively inexpensive. But using this link, you can fill out a form or application to get a bunch of naloxone sent to your program that you can legally distribute to people who might need it for harm reduction measures. So those are two of the easiest ways and most cost-effective ways to obtain naloxone. Now, naloxone is not our only option. It is our most popular option and probably our most accessible option, but I wanted you to be aware of the different types of naloxone that are available. We have brand name Narcan, which has been probably the most commonly seen and used. That's part of our standing order. We also have its generic version, the naloxone 4 milligram spray. This is what is available over the counter and what is most commonly sent when it's done through some of these different programs. We also have Cloxato, I hope I'm saying that correctly. This is just a higher dose of naloxone. So this was in response to some of our synthetic opioids that need higher doses due to the potency of the drug. And so Kloxxado is the same medication. It's still naloxone, but it has 2 doses of 8 milligrams of naloxone instead of 4. So that could be an option, especially if you are seeing that your naloxone product is not being as effective in your patient population. Hopefully you don't use it enough to see those trends, but if you do, that is an option for you. And then we also have another agent that is very similar to naloxone, but technically a different drug. Nalmefene has been available in the hospital setting as an injectable medication for a really long time, but within the last year or two, it has a nasal formulation too. So it's use it the exact same way you would naloxone or Narcan, but this is going to last longer in the body, and it is going to main pro is that it lasts longer in the body. It's going to have the same onset of action as naloxone, but it lasts up to 4 hours in the body. And again, this is going to be in response to some of our synthetic opioids that are lasting longer in the body than our naloxone. This is not covered under our standing order as it is written right now, and it's also not over the counter. So this is something that you would need to put an order in with the pharmacy with the prescription either for your entity or for your organization in order to receive it for that organization. But it is another harm reduction tool that we can have in our toolkit. And so that I highlighted our generic naloxone spray. This is what we are getting from the state. Now let's look at how to actually use naloxone. I'm going to switch my screen to the naloxone training so I can put captions on it so it's a little bit more accessible. I will mute myself. If you can't hear it, someone definitely let me know in the chat.
Hi, I'm Allison, a pharmacist, and today I'd like to go over how to use your naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in the event that you witness an opioid overdose. So you've called 911 and grabbed your naloxone. Now what? This is Narcan nasal spray. It comes in a box with 2 doses. You're going to take 1 dose out of the box, remove it from the packaging, and the applicator goes in 1 nostril, and you're going to depress the plunger with a quick, firm push. When putting in the applicator, you'll want to form a tight seal at the patient's nose so that the medication goes up into the sinuses and does not come down the face. And then with a quick, firm push, you're going to administer the medication. There's no need to depress the other nostril. You can leave it open. And if a second dose is needed, you will apply it in the other nostril than the one that the first dose was given in. And that's how you use the Narcan nasal spray.
All right, so pretty straightforward. You literally do just put that plunger in the nose and depress the plunger, and it absorbs in that mucous membrane inside the nose, so that pink moist area. For this, I did put the link in the slides, and I also put the link at the very end of the PowerPoint, but that video was recorded by Kelly Ross Pharmacy over in Seattle, and they're great advocates for harm reduction measures and do a lot to supply naloxone and Narcan to those who need it. So they're a great resource if you are on that side of the state. For naloxone, you cannot reuse it. So once you have used the naloxone, it is done. That is why they put 2 within the packages. So if you need a second dose, you can use the second dose in the box, but you cannot reuse that plunger that you just depressed. The other question I get a lot is, but what if my patient's not breathing? Are they still going to see the effects of the drug? Yes, it was designed for people who are not breathing, since that is the #1 sign of an overdose for opioids. So as long as they are able to access that pink mucousy moist membrane in the nose. That's where it's actually getting absorbed. It's not getting breathed in or anything like that. So pretty straightforward, and definitely the most accessible is that intranasal formulation. So when you do encounter an overdose situation, there are 5 main steps that you're going to want to address, and here they are. So the first thing we're going to do is we're going to kind of evaluate the scene, just like with CPR. You want to check for signs of opioid overdose, and you kind of want to just take in your surroundings, mostly to make sure that you are keeping yourself safe. That is a priority as well. Our most common signs of an overdose, there are plenty, but 3 I want you to focus on, and the 3 that are easiest to remember are going to be slow or stopped breathing, somebody whose body is limp and non-responsive, either to physical or verbal stimulation. And then if they do have fingernails, so the beds of the fingernails, if those are blue, or if you're not able to check their fingernails, you can check the inside of their lip, down at their bottom lip. If that is blue, then they are likely not getting oxygen to the very important parts of their body. So if they're not getting oxygen to their fingertips and their lips, they're likely not getting it to their brain either. So these are the primary signs of an opioid overdose. How can you check for these signs? If you know the person, calling their name and physically asking them to wake up or become aroused is the #1 thing you want to do. If they are not responding to your verbal or physical arousal cues, then you can get a little bit more forceful. And so what we typically do is called a sternal rub. And so this is where you use your knuckles, kind of the real bony parts at the end of your hand, and you rub it along their sternum. And so when you rub it along their sternum, you want to make sure you do it with force. It is meant to hurt because it's meant to see if they are able to respond to you, right? If it's able to kind of wake them up, almost is a way to picture it. If you don't feel comfortable doing that for a variety of reasons, you can also do the same mechanism with your one finger, usually a pointer finger, or middle finger is kind of hard to do, so usually a pointer finger, using that knuckle to drag across the upper lip. If you drag it across the upper lip, you want to do so again with force, enough force for it to be slightly painful so that you're waking somebody up, so that you're able to arouse somebody from really not responding. And if they are still not responding after those 2 measures, then we can say there's likely some type of emergency situation going on here. If you suspect an opioid overdose, then we're going to continue with the other response steps. If they do respond to this step, you want to see if they maintain that response. So if they're even coming in and out of consciousness, if I'm not able to keep somebody aroused, I am going to continue on with the next steps as well. So the next step is to call 911. So if somebody is not responding and you've done all of these steps, regardless of what the situation is, it's an emergency situation. So you're calling 911 and you're explicitly verbalize that someone is not breathing. This allows them to bring the tools they need to reverse an overdose. Nowadays, it is a lot more common for every unit to have naloxone on them, but this ensures that that happens. You want to give a clear address or description of your location, which sounds easy and is not. I don't know how you deal with stress, but I don't operate under stress super well. I was getting my oil changed the other week and they asked me to check my blinkers and I just blanked and I was like, I don't know if I have blinkers. And they're like, ma'am, you definitely have blinkers. So if you're like that in an emergency situation, it could be helpful to have your address printed out where you keep your naloxone, and that's just able to give them the directions they need to get there as quickly as possible. This is where I would like to remind you and others that Good Samaritan law in the Washington state is one of the most comprehensive Good Samaritan laws. What it does is it provides protections when calling 911 to save a life, even if drugs are at the scene. This doesn't just protect you as the person getting help, it also protects the person receiving help. This law also protects you from administering naloxone on another person. So as long as you're doing it with good faith that you are trying to prevent further complications, this law is protecting you in those different aspects. All right, once we have checked for signs of overdose, called 911, our next step is to administer naloxone. So with our intranasal naloxones, again, it's super easy. You just put it in the nose and depress the plunger. But I want to remind you, it only lasts for up to 90 minutes and multiple doses may be needed. If you do need to do repeat doses, it will, you will want to check for a response for about 2 minutes, which feels so long when you're waiting those 2 minutes. But the response we're actually looking for is just some type of return of breath. So you can look at their chest and you can look at kind of feeling under their nose if you want to assess if there is some breathing going on. Not all patients are going to pop up and have this quote unquote Lazarus effect that some people describe. So they might not pop up and become conversational right away. That's okay. It doesn't mean the naloxone's not working. The naloxone's working when we do have some breathing returning. If you don't see any response within those first 2 minutes, you can go ahead and give a second dose to see if that provides a response from there. If you don't see any response after multiple doses, it could be that there is a different emergency scenario happening. That's okay. You have already called 911 and naloxone is not going to make that emergency situation any worse. Some get a little bit cautious when it comes to reversing an opioid overdose. Other use disorders like benzodiazepine use or alcohol use does have death as a side effect of their withdrawal. This is not the same with opioids. With opioids, you can die from the long-term effects of chronic withdrawal, specifically the dehydration involved with chronically being vomiting or diarrhea, and that kind of dehydration that gets involved with it can result in death. But the immediate implications of reversing that opioid overdose will not cause that person to die from the reversal. So it is safe to reverse an opioid overdose. Once you have administered that naloxone, you're then going to support that person's breathing. So that can look different based off of your level of comfort. Again, your comfort and safety should always be a priority, even in this situation. So the recovery position can be used. That's where they get rolled onto their stomach using their inside leg and arm to help prop up their body. This helps clear the airway, and if there is any type of vomiting, there is no aspiration based off of the position of what we're putting them in. We do want to also make sure that that patient's airway is clear and that nothing is covering it. So specifically, if they are wearing a mask or anything that is over their face, you just want to move it out of the way so they're able to get the most oxygen. You can do CPR if you do feel comfortable, either hands-only CPR or traditional CPR. But that is, again, if you feel comfortable. Usually in situations where you know the person is where you might feel more comfortable. Otherwise, the recovery position is still a very good support to that person's breathing. And this is where I'll just plug that in this scenario, it is always good to have PPE on hand. Remember, you can't absorb fentanyl through your skin. Your skin is a phenomenal barrier. You can't absorb other opioids either through the skin unless it's in that patch form and it's specifically designed for that. But in order to go into some of these situations, using a mask or gloves can always be helpful, especially if you do have them. All right, so once we have checked for signs, called 911, administered naloxone, and supported their breathing, then we're going to monitor the response. So this is our last step to do until EMS arrives. So remember, it could take a little bit for them to respond to the naloxone. So we're going to monitor them and keep administering naloxone until we do see a response. And always keep in mind that they may need supportive services. So just being upfront with that when the patient does return to consciousness and they don't want to go to the hospital, just explaining that those opioids could last longer in the body and they might need a little bit more support, or at least keep naloxone on hand in case anything happens. If you are doing this as part of an organization or as part of your job, you also might want to consider adding a 6th step, which is to debrief after the administration. In any life-saving measures, whether it is a hypoglycemic attack, a severe asthma attack, or the reversal of an opioid overdose. It's a really stressful situation, and sometimes things don't always go as planned, but having a really safe debrief can help improve processes for future instances if they do occur. Especially knowing that this is a new process for a lot of different entities, it is recommended to do a debrief. So you want to include everyone who is involved. You want to be timely, but you do want to be sensitive that this is a stressful and emotional situation. So you might want to do it maybe 2 to 3 days after the overdose has occurred to allow people time to digest and support their own mental health. But you don't want it to go too long that people start forgetting some of the details, what has happened. You want to create a safe environment, even if things don't go as planned. So giving a couple days buffer in between also helps us respond a little less emotionally, and it helps us to identify what went right and what went wrong and be able to see that as a matter of fact, as opposed to as a matter of emotion. You want to listen actively and take notes. So again, this should be a good discussion, but if you assign one person to take notes, it can help you actually integrate that into action for changing or updating your process in the future. And so you do want to update those policies and procedures as needed, provide education as needed. Maybe someone missed the naloxone training, or it's been a while since they took it, so the steps were a little clunky in between. You can always re-educate. And you always want to reorder that naloxone to make sure that you're replenishing your supplies. All right, so that is the end of my training, but I would love to answer any questions if there are any questions from